Good afternoon, everyone. Welcome to the first of our four-part webinar series, Rheumatology Revealed 2.0, Advancing Insights and Evolving Best Practices for Family Physicians, hosted at the Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sher, and I'm the Associate Dean of the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. The University of Alberta, its buildings, labs, research stations are primarily located on the territory of Niihau, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe, lands that are now known as parts of Treaties 6, 7, and 8, and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I'd like to start with some housekeeping information. If you have questions or technical difficulties about the logistics of the program, please use the chat function. But if you have a question for the speaker, please use the Q&A feature on the bottom of your screen. Please have a look at what's already been asked and upvote those questions you'd like answered. We have a hard stop at 1 for clinic, so we can't guarantee that we'll be able to respond to all of your questions, but please put them in the Q&A, and Natasha will record them, and we'll endeavor to send some responses to them in the Pearls document that you'll receive with your recording about a week after the event. So everyone will receive that email with the recording, everyone who registered. You can claim CME credits and complete a personal development activity using the My L3 Plan tool. So for more information, please visit the QR code. This activity has not been formally reviewed by the CFPC or Royal College, but it is eligible for non-certified credit. And Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise. I'm so thrilled for today's session. I enjoyed 1.0 so much. I'm looking forward to 2.0. And we're delighted to welcome Dr. Anna Oswald, who's going to be presenting on rheumatology, biologics, and primary care, practice managing risks, interaction, and patient care. So Dr. Oswald is a full professor in the Department of Medicine at the University of Alberta. She spent a year as a visiting scholar in medical education research at McGill's University's Center for Medical Education, and completed a master's in medical education at the University of Dundee. She maintains an active rheumatology practice and is an active teacher with clinical teaching and classroom teaching at all levels, undergraduate, postgraduate, faculty development. And she's recipient of local and national teaching awards and grants, including the University of Alberta Rutherford Award and McCalla Professorship. She's a clinician educator for the Royal College of Physicians and Surgeons of Canada, and a U of A director for competency-based medical education for PGME. So thank you so much, everyone, for your time, and welcome everyone to 2.0. Thanks, Anna.
Thank you, Denise. Let me just take a moment to share screen here and to start our slideshow. Okay, well, I thank everyone for coming today and participating, and for those who'll be listening online later on. I am in the clinic today, actually, and so I'm on AHS Wi-Fi, and I'm hoping that it will hold for us. As Denise said, I welcome your questions throughout, and Denise will be moderating the questions for me at the end. So we're talking about biologics today, and there's a little bit of a forest and a trees feeling in this space, hence my photo here. And so like every educator, I can't help but to have objectives. And so I thought these might be some relevant objectives for this group. To identify factors contributing to optimal patient care for those on biologics and targeted synthetics, to talk about common and important risks, and to incorporate practices that you can participate in to contribute to adherence and safety for these patients. I don't have any disclosures relevant to today's talk. However, I will use some trade names because in the biologics land, the names are very confusing. The molecular names are quite a mouthful and are difficult. So I will allude to some trade names in this talk. So I just wanted to disclose that. I wanted to start us off with a few cases just to kind of set the stage for some patients that might sound like something you may have seen in your practice. So this first patient is a 54-year-old woman diagnosed with rheumatoid arthritis a year and a half ago. Initially, she was on methotrexate parenterally, 20 milligrams plus hydroxychloroquine or Plaquenil, 200 milligrams. And she had some improvement in her patient global score, in her number of swollen joints. They improved by about half. Her CRP normalized. And so she was escalated in her DMARD therapy to leflunomide with Plaquenil or hydroxychloroquine. And she had a little bit of further improvement. And this is where she's at. Patient global 4, 3 swollen joints, normal labs. What are our options? And I often do get notes or faxes or calls from family doctors about patients in this exact situation. So I wanted to bring this case forward and let you know what's kind of going on this side of the equation when we're looking at patients in this situation. The next is when I was actually called about when I was on for phone consults. This is a 62-year-old man diagnosed with rheumatoid arthritis 3 years ago. He had failed several conventional DMARDs or disease-modifying antirheumatic drugs, and he had been started on adalimumab. The trade name for adalimumab is Humira. There are numerous biosimilars now used for adalimumab. And he'd been on that for a year and a half. He was in clinical remission, zero swollen, low patient global score, normal labs. But each week he'd get a fairly large 3 to 5 centimeter raised itchy lesion at the injection site. It would settle after a couple days, but increasingly it was bothering him. And he's come to see his family physician about this issue, wondering if he should stop oh, I put the wrong drug there, adalimumab. It could be etanercept just as equally. And his next appointment with his rheumatologist isn't for 4 months. So what can we do for this patient? What are our options? What are the pros and cons of those options? And then the final patient, 71-year-old woman diagnosed with rheumatoid arthritis 10 years ago. She has known type 2 diabetes, and she's failed several conventional disease-modifying antirheumatic drugs or DMARDs. She's also on adalimumab. She's been on that for 8 years in clinical remission. And she presents to your office with what looks like cellulitis after a mild vesicular zoster infection. She did not have her Shingrix due to cost, and you've elected to treat her initially with 5 days of oral antibiotics, but she had poor response, so you chose to extend it to 10 days. And what are the considerations for a patient like this who is on biologics in terms of maintaining safety and monitoring for that? Okay, so I'm going to back up. In terms of arthritis treatment, and I'm going to use rheumatoid arthritis as an example today, but almost all of these principles apply to those with psoriatic arthritis, lupus, any type of autoimmune or inflammatory arthritis. So our approach to treatment in inflammatory arthritis is really there's pharmacologic and non-pharmacologic. And there are many non-pharmacologic options that are really important around maintaining function with physio, ensuring that they can complete their activities of daily living, etc., with occupational therapy. Encouraging exercise is actually a really important modality, smoking cessation, education around their disease. This doesn't mean they go to college, but that we have a chronic disease education program for people with rheumatoid arthritis, and those are actually very important. But today I'm going to focus on the pharmacologic side of things. And when we talk about pharmacologic therapy, there's symptom control, as in I need to get through my day, where we use things like non-steroid anti-inflammatory drugs or NSAIDs. We might use steroid injections. We might use short little courses of steroid just until they're bridged to a functional DMARD, a disease-modifying agent. And so that's symptom control. We kind of consider that separately from long-term disease control. So disease control is achieved through a number of different types of disease-modifying anti-rheumatic drugs, or DMARDs. And there are conventional and biologic DMARDs. They fall all under the category of DMARDs, or disease-modifying anti-rheumatic drugs. And the reason DMARDs are so important is they prevent disease flares so that we don't need symptom control drugs. They prevent disease progression so that the patient doesn't get damage, deformity, or decreased function. They prevent extension of the disease into other organs like lungs, eyes, spleen, bone marrow, and heart. And most importantly, they prevent death. And we know that patients who are well controlled with rheumatoid arthritis on DMARD therapy have a life expectancy that is 21 to 26 years longer than those who are not on DMARD therapy. And so patients often say to me, Doc, is it okay that I'm on this for so long? And I say to them, actually, it is unsafe for you not to be on these because it will shorten your life expectancy by 20 to 25 years without DMARDs in a rheumatoid arthritis patient. So that's some of the rationale for DMARDs. Some of the other principles around DMARDs is that we really espouse an early aggressive therapy standard. We have this concept of a window of opportunity for clinical remission, and usually that happens most easily if we can get someone in control within the first 6 to 12 months of symptoms. So we don't start small and then go bigger and bigger and bigger, stepping up. We start big and then back off partly, but not all the way. And combinations of disease-modifying agents work better than monotherapy. We have a lot of literature around that. And so the goal is earlier remission with close follow-up. And so I'm going to talk about some of the jargon or the lingo because biologics, there's a lot of mouthfuls here, and there's a lot of lingo or jargon. So first of all, when we talk about DMARDs, we have conventional synthetic DMARDs. And those are the classic medications that I'm sure you know, things like methotrexate, hydroxychloroquine, or Plaquenil, sulfasalazine, leflunomide, or Areva. And these are all chemical structured drugs. The vast majority of these were developed for other purposes. Methotrexate was developed for cancer therapy, and it's used in an extremely low dose weekly in arthritis care. Hydroxychloroquine was developed as an antimalarial, and then it was found to be effective in mild inflammatory arthritis. So these were really serendipitous discoveries. And all of these, being chemical structures, can have a generic form of their medication. We also have a newer class of medications that falls within the umbrella, sort of biologics. We use the term biologics for them loosely, but technically, these are targeted synthetic, or TS DMARDs. These include things like the Janus kinase inhibitors or JAK inhibitors, and you may have heard of things like tofetasidenib or Xeljanz, upadacitinib or Rinvoq, baricitinib or Oleant. And so the nib part of those names of tofacitinib, etc., refers to a small molecule inhibitor, and in this case, cititinib refers to a kinase inhibitor. So these ones are kind of in the gray zone. They're chemical structures, but they're designer drugs, specifically designed to target specific immune pathways. And so there are actually generic forms available of these medications, but they are similarly expensive to our classic biologics in the range of $20,000 a year. So these ones are called targeted synthetics, and the most classic ones are things like JAK inhibitors. And I think through COVID, we all became familiar with more of these medications. Then we move on to the MABs. You'll hear about all sorts of MABs. These are classic biologic disease-modifying antirheumatic drugs, or DMARDs. And I alluded to some like adalimumab, certolizumab, golimumab, rituximab. There's all sorts of MABs. These are antibodies. So I couldn't decide if I should put this here, but I thought it's been a long time since many of us did immunology. And so this bottom part here is the constant region of an antibody. And this red part on this diagram is the variable region. And so in the case of infliximab, they have used molecular technologies to splice in precise designer variable regions to target specific cytokines. And in this diagram, that's red because infliximab was the first to do that, and they did it using mouse proteins. Subsequently, adalimumab did that using humanized proteins. But this is the business end of a MAB, and that is what they are genetically engineering and designing for their particular targets. And so monoclonal antibodies, this is a monoclonal antibody, and so is this one, are designed for specific targets. And they can block the action site on immune cells. They can actually mop up extra cytokine in the circulating area, or they can even stimulate, depending on their structure. But most of the ones that are used therapeutically block action sites. And we'll come back to this topic of biosimilars. My final lingo slide is the concept of septs. So you'll hear drugs called etanercept or abatacept. Sept means it's a soluble receptor, and that's what this picture is. What they've done is they've taken the constant region of an antibody, the bottom part, And instead of splicing in a specific targeted part of the antibody, they've spliced in a soluble receptor. So this soluble receptor will be for a specific target, like TNF alpha or tumor necrosis factor alpha, which is a cytokine implicated in rheumatoid arthritis. And circulating antibodies, they bind to these antibodies and to the effector molecules like the TNF, essentially to like mop it all up. So it's like the receptor has been taken off the cell surface and is circulating all around to act as a sponge or a mop for the cytokine before it can reach its target. So that's how these things differ. There's a lot of complicated protein structures, and that becomes relevant in a minute. Okay, so I'm just going to go back to some of the considerations when we pick conventional, targeted, synthetic, or biologic disease-modifying agents. So as I said previously, conventional synthetic DMARDs are these classic ones that we know. They're cheap. They're often a bit slower. They can take 3 to 6 months to see full effect. And they often come with a few more nuisance side effects. Not everybody gets nuisance side effects. Probably 80%, 85% of patients don't. But a significant minority do get nuisance side effects. And when I say nuisance side effects, I'm talking about things like nausea, vomiting, oral ulcers, malaise, etc. But there's very few serious side effects with these medications. They are really relatively safe. And in order to be progressed to advanced therapies, typically most plans and certainly government plans require you to fail these agents in order to access the advanced therapies. And for a long time, we had in our minds that advanced therapies like biologics were better than conventional synthetic therapies. But there was a landmark trial in the New England Journal that showed actually triple conventional therapy. So the trial was done with methotrexate, hydroxychloroquine, and sulfasalazine, produced equal efficacy to a TNF biologic with methotrexate. And that was a game changer at that time because it really changed the philosophy that biologics are better. And we'll come back to that. However, they may be better tolerated. So it may be difficult for some patients to tolerate the combination of methotrexate, hydroxychloroquine, and sulfasalazine. And because rheumatologists are nerdy people, when we sit around sometimes in the evening at dinners, we'll have this conversation and we'll say, well, if it was up to you, would you take triple conventional DMARD with a bunch of nuisance side effects and very little risk? Or would you take a biologic TNF alpha inhibitor with methotrexate with fewer nuisance side effects, but maybe a smaller but real risk there? And the room is always split. There is no right answer there. This is my attempt to kind of show not precisely some of the thinking. So if I could make this and my design skills were better, I would kind of superimpose the combos with the biologics because I just told you those are just they're equal in efficacy, at least a triple combo is. Our workhorse medication is methotrexate, and like I said, some nuisance, few serious, cheap. An add-on or adjunct therapy is typically Plaquenil or hydroxychloroquine, weaker, slower, cheap, very few side effects. And then we come over to our advanced therapies, which tend to have very few nuisance side effects. People feel great, but some serious side effects I'm going to discuss. And cost is certainly an issue here. Okay, so as I already mentioned, there are some uncommon but serious side effects for biologic and targeted synthetic disease-modifying agents, and they are expensive. The innovator versions are all around $20,000 per year, and the biosimilar version costing is not transparent and is variable and ranges somewhere between $11,000 and $16,000 per year depending on the agent. And there are very strict rules to access these and to continue accessing these. I've put some examples here. So I'm just going to move the faces out of the way so I can see this fully. There we go. Okay, so I tried to put some examples, and this is a busy slide, but just to say, I recognize that this space is ever growing and there's so many medications to keep track of. And it's hard, even for us who work, exclusively in this field. And I can only empathize with those of you who intermittently play in this space. And so we have anti-TNF agents as our kind of oldest. These came around in the mid to late 90s. And there's numerous different kinds of anti-TNF agents. They're used for lots of indications beyond rheumatology. They're used in GI for IBD, Crohn's, colitis, etc. And I just put some examples here so we can know what we're all talking about. So things like infliximab or Remicade, etanercept or Enbrel, adalimumab or Humira, golimumab, Simponi, etc. And then we have other interleukin inhibitors that are MABs, so monoclonals. IL-6 inhibitors like tocilizumab or Actimra, IL-17, secukinumab or Cosentyx. These IL-17 ones are actually indicated for psoriatic arthritis, not rheumatoid arthritis. Same with the IL-23. And so you'll see those in different settings. And then we have B-cell inhibitors, rituximab, known as Rituxan or other biosimilars. We have co-stimulation blockers, abatacept or Orencia. And then, as I mentioned, the targeted synthetic molecules, the JAK inhibitors, and the phosphodiesterase inhibitors are also in this class. So it's a busy space. So I wanted to pause now and just talk about biosimilars, as many of you would have seen your patients over the last number of years being transitioned over to biosimilars, and there's a lot of questions that patients bring. And so I just wanted to give you some background. So when a patient comes to you and says, what is this thing? What do you think of it? I know that you have the luxury of seeing your patients more frequently and having longer term relationships and that trust with patients more than we have that opportunity. So often we'll, say to a patient, we're going to switch you to a biosimilar, and they'll come to you and say, she said this, what do you think? Is that for real? And so here's some background on biosimilars. So as I mentioned and tried to demonstrate in the image, biologic medications and monoclonals and soluble receptors are large complex protein structures. These are not chemicals. They're folded three-dimensional large proteins, many of them immunoglobulin based. And so you can't make these as a generic. And the innovators aren't required to release their precise recipe of how they make that drug at the end of patent. And so the biosimilar market came into play when companies tried to, without the detailed recipe, make the closest possible version of these drugs. And so they would study, with complex molecular technologies, what are the structures of these drugs, and they would try and make them as close as they could. And they would have to prove that there was safety and efficacy that was the same as the innovator molecule. When these first came to market, there was a lot of skepticism and mistrust around biosimilars. And biosimilars are known to have what's called, instead of a placebo effect, a nocebo effect. The initial unblinded studies showed poor efficacy. But subsequently, when they blinded both the doctors and the patients so that nobody knew whether they got innovator or biosimilar molecules, they showed equal efficacy and safety. And the feeling was that we all project that we think they're not going to work, but actually they do. And so they call it the nocebo effect. And yet there is good data now to show that they have equal efficacy and safety. And we don't have much choice because almost all public and most private plans will now require at the very least new starts to be on biosimilar, but most of them have all required switchovers from existing patients as well. So you'll see your patients being switched to these biosimilars. There are some advantages of biosimilars in addition to the cost savings for our system. Some of them, in order to be competitive, have improved upon some of the preservatives to make them sting less or cause less injection reactions and so on. So that's a real bonus of this evolution here. I want to go over the access rules in Alberta just because that does have a lot to do with some of the decisions we make in the clinic, because this is a real practical consideration. So the government-based non-group Alberta Blue Cross, or ABC, has strict criteria, and patients who are on any kind of income support, AISH, any of the government plans, Alberta Works, Seniors Blue Cross, all of those patients will have these criteria. And even if they don't, we tend to run them through these criteria, make sure that they've qualified in case they lose their private plan. Numerous times I've seen people who've changed jobs or left a partner whose plan they were previously covered by, and then suddenly they're without a plan. And if they haven't previously met government criteria, they won't be eligible for drugs. So we usually try and make sure people have met government criteria, even if they have private plan. And so I put an example here for rheumatoid arthritis. Rheumatoid arthritis, Alberta Biologic Access requires 3 months of methotrexate taken subcutaneously weekly with some other conventional synthetic DMARD, which is not leflunomide. They're not allowed to combine with leflunomide in that step. And then if they don't have good effect, they have to go on to another 3 months of leflunomide. And then if they don't get a good response, anybody at that point can get biologic, except there's a catch. The way the government has framed their programs is anyone can start biologic, but at 3 months, they will stop their biologic unless they have a disease activity score improvement of 2.1. And just to give you some context, remission, low disease activity, is about 1.7, 1.8. So if someone's disease activity score isn't above, the 4.5 level, at 3 months, they will be cut off that drug and they will never be funded again. And that's quite surprising to many physicians, but they're marked in the provincial database if they don't improve by a disease activity score of 2.1 as a quote, non-responder, never fund again. And so that's quite serious. And we try really hard to make sure no one ends up as a non-responder at 3 months, which means they have to have enough disease activity to be able to come down by 2.1. And I actually had a patient who had excellent response, had not been able to work and support herself, was able to work on after we started biologic, but she didn't quite meet the 2.1. It was early in my career. I was naive and didn't realize how these things entirely worked. And they pulled her drug at 3 months. And I wrote to them and I said, look, this woman was going to be on income support. This is, much more economic for the government to have her on this drug. I'd really like you to reconsider. She's doing better from a mental health, from a physical health. She's working. And they said, no, these are firm rules. It's not appealable. And so we're very careful who goes on to DMARD. They have to be able to improve by that score. Other things that aren't always known by our colleagues is, I'll get letters that say, can you just try a different one? Can you switch them to something else? That is a huge big deal, actually. The only way I can get funding for an alternate biologic medication is if I write to the government and say, we've lost effect. This drug is no longer effective in this patient. And then they mark them in the provincial database, secondary non-responder, do not fund again. Or I have to say severe adverse reaction. And again, they get marked in the provincial database, severe adverse reaction, don't fund again. And so these are permanent notes that go in their file for any government-based plan, and you can't go back. So I can't then, if I am on biologic 1 and I'm like, it's not bad, I'll just try another one. If the other one is even less effective, I cannot go back to the first one. It's always a one-way switch. So that really does influence our decisions when we're looking at biologics. The other question I get is, should patients go on a drug holiday? Maybe they'll just take a break for 3 months and then see how they feel. We strongly recommend against that. We have good data around perioperative cases where we have to pause biologics, where 25% do not recapture control, and then we end up cycling through other drugs trying to regain control. So we don't recommend drug holidays. I have a typo there, pardon me. Some drugs do require flare to continue, and the example is giant cell arteritis. In that disease, we're required to cause the patient to flare before they will continue after 12 months of biologic. And so that's always a little bit scary, especially if a patient has had a sight loss with that event. And so I try to write appeals in that case, and sometimes those work. So I want to talk a little bit more about safety of biologics. And there are some really important safety considerations here. For all classes of biologics, be they TNF or cytokine inhibitors or small molecule targeted synthetics, infection is the biggest concern. And anytime I start a patient on biologic, out comes the Dr. Oswald waggy finger and I say, you need to buy a thermometer. It needs to be digital. I don't want some kind of Band-Aid thing going on your forehead. I want you to have a digital under the tongue thermometer. If you feel sick, you need to actually take your temperature. And if it's 38 or higher, you need to see a doctor to determine if you need antibiotics or not. If it's a viral infection, we don't tend to hold biologics unless it's severe, but a bacterial infection requires biologics to be held and requires prompt treatment. And so any active infection makes us very nervous. I had a patient just last week in clinic who had been admitted, had severe nutritional challenges, and was meant to start a biologic, and in the interim developed a bed sore. So I had to bring her back in and have a look and see, like, is this thing healed? Does it look infected? Like, it's really important that we make sure there's no active infection when patients are on biologic. Likewise, untreated hepatitis B or C are a problem, and latent TB can reactivate on these medications. Patients cannot have live vaccines, which is a big deal right now with our measles outbreak, and has caused some challenges. So they need to be off biologic, and I recommend doing that in conjunction with your rheumatologist and public health if that's needed. If they're undergoing active cancer treatment, we hold biologic because typically those treatments are also quite immunosuppressive. And then a relative contraindication, I would say, is patients with recurrent non-melanomatous skin cancers, and I'll come back to that topic of cancer in a minute. And then there's some specific contraindications to specific classes. And so in anti-TNF agents, heart failure, advanced heart failure is a problem, multiple sclerosis or other demyelinating diseases, and both of those two issues came up because of large trials using anti-TNF agents to treat multiple sclerosis, to treat heart failure, that had to be stopped prematurely because patients were dying or doing badly in the treatment arm with those diseases. So those are now contraindications to these medications. And then these medications can cause drug-induced lupus. We don't use them in patients who have lupus. Anti-IL-6 like tocilizumab, diverticulitis, diverticulosis, or risk of bowel perforation is a contraindication or relative contraindication we have to watch very closely. And patients at risk for zoster who've had recurrent zoster. And then JAK inhibitors, we worry about DVTs or PEs and zoster. And there's some controversial data that's not quite sorted out around whether or not cardiovascular disease or pre-existing cancer should be a contraindication. And so our screening looks at infection, TB, so a skin test plus a chest x-ray, or an IGRA plus a chest x-ray, serologies for Hep B and C, a vaccine review if they need live vaccine, let's do it before we start. We will do screening for drug-induced lupus, and then IL-6 inhibitors can cause hyperlipidemia, and we try and make sure that they're vaccinated for Shingrix before starting those issues if we can. Okay, so some common and less common but serious side effects. The common things are infusion reactions for IV preparation, so people feel achy, maybe a little bit of an itchy rash. Rarely they can have anaphylaxis, but more commonly it's a low-grade infusion reaction. And then injection site reactions, which is that itchy hive-like lesion. The less common but serious one, really, as I alluded to, is bacterial infection. Now, I did have a patient who came and told me, I'm not going on those biologics because I'm going to get an infection and die. So I just want to put it into context. Infection is very serious on biologics. However, it is not common. It is 1% per year overall. Now, clearly, there are some people who have a higher or lower infection risk. But the way we manage infection, in addition to educating patients to own a thermometer, take their temperature if they're sick, present for assessment within 24 to 48 hours, is we partner with you, our family medicine colleagues, asking if you can please see them relatively quickly to consider for antibiotics. We have a fairly low threshold for antibiotics if there's suspicion of bacterial infection. And if the patient has bacterial infection, then we hold the biologic for the duration of the infection and antibiotic use. So we don't typically hold for viral infections unless they're severe, but we do consistently need to hold for bacterial infections and for the duration of antibiotics. And then, as I wrote, some other less common and serious issues is latent TB, infection activation, and a slight increased risk in non-melanomatous skin cancers. Just some COVID consideration. We still are seeing COVID, as we all know. Patients on anti-TNF agents actually had improved COVID outcomes. Those on abatacept, so Orencia is the other name for that, or rituximab, had worse outcomes with COVID. And those on the IL-6 agents like tocilizumab or Actemra and JAK inhibitors probably were improved, though the trials were not adequately powered, and those are used in COVID therapies. So we feel those are likely safe in COVID infection. Okay, what about the C word? Cancer. Always comes up. So, first of all rheumatoid arthritis and psoriatic arthritis patients have increased risk of heme malignancies like lymphoma, myeloma, leukemia, especially lymphoma. Without any drugs on board, they have this risk. They also have an increased risk of non-melanomatous skin cancer. There is no increased risk in lymphoma for anti-TNF agents in rheumatoid arthritis. When we look at those who were treated and those who weren't, and they've done some very large studies in the UK and in Sweden, they've shown that actually what we thought was a drug-induced lymphoma is a rheumatoid-induced lymphoma, and just the worst patients are more likely to get lymphoma, and the worst patients are more likely to get biologic drugs. And so this has been disproven. Both methotrexate and biologics give a small increase in non-melanomatous skin cancers. So rheumatoid gives an increase in non-melanomatous skin cancers, methotrexate gives a further small increase, and biologics give a further small increase in non-melanomatous skin cancers. And there's some controversial evidence that methotrexate may cause a very small increase in risk in actual melanoma. I'd say watch this space. There's a lot of trials about that right now. Okay, what can you do to help patients achieve better efficacy? First of all, encourage them to continue their concurrent conventional DMARD like methotrexate. Patients who are on advanced therapies like biologics or targeted synthetic agents have 20% improved efficacy and outcomes when they're on methotrexate with their biologic. And the feeling is, or the science actually, not just the feeling, is that methotrexate suppresses the production of anti-drug antibodies that are the number one cause of secondary failure. So when it works initially and then stops working, typically we find anti-drug antibodies. So if I put someone else's immunoglobulin in your body, eventually your own immune system will try and target that and neutralize it. And the methotrexate prevents that or reduces the chance of that so that the drug will work for longer. Really discourage drug holidays. That is a way for biologics to not work. It kind of alerts the immune system when we have the drug here, not here, here, not here, on and off, that there's something foreign here that we should neutralize. Adherence is huge, huge with these medications, like all medications, I'm sure. But we have lots of troubles with people not taking their medications. And then we know that the first biologic a patient takes has its best chance, with decreasing success with each time we switch. So we try and really maximize first biologic if we can. Okay, so I'll come back to our cases now. The first case, this patient sadly probably wouldn't meet a 3-month criteria. This patient's disease activity score is probably somewhere in the 3s with those scores. And so they could start a biologic, but it would be unwise to do so because they wouldn't be able to continue it after 3 months. So what are our options? We can wait till they're a little bit worse. We can add a third agent like sulfasalazine. We could look at maybe sometimes we might withdraw an agent to see if they get a little bit worse and meet criteria. There's all sorts of options, but this is the one that's really tricky. And we'll get notes from our colleagues in family medicine saying, like, why aren't we progressing here? And it's just that tricky interface of trying to make sure the patient will succeed at their 3-month renewal visit, that they're bad enough to meet criteria of improvement. This case is the one with the big itchy raised injection site reaction. So as I mentioned, here we would not be keen if he has good response to switch him because it will be a one-way switch. It's likely he'll have those reactions with a second agent, and we can't go back if it doesn't work as well. But there are things we can do for these. So some people find if they really make sure that the drug is out of the fridge for a good long time, it's at room temperature, they'll get less infusion reactions. Some people find if it's colder, if they put it in the freezer for just 10 minutes before, they have less infusion reactions. Sometimes we give a predose of Benadryl, or some patients, there's a study that shows if you give them Singulair Montelukast, 2 days prior, 2 hours prior, and 2 hours after, that you can reduce injection site reactions. So there's some things that we can try to work on rather than discontinuing the drug or going for a switch. Okay, and this is a patient who comes in on long-standing adalimumab monoclonal biologic who comes in with a cellulitis requiring antibiotic. So a couple things here. Shingrix is expensive. It is really challenging. A lot of these patients can't afford it. Whenever possible, to counsel them if they can afford it to get their full vaccinations for everything, including Shingrix. But this patient, if we're prescribing antibiotic, the hand that prescribes the antibiotic needs to tell the patient to hold the biologic until the antibiotics are completed. And so that's the key issue here. Getting the patient in quickly, low threshold for antibiotics if suspicion of bacterial infection, and hold, most importantly, hold the biologic during antibiotic courses. And so that's all I have. And I turn to Denise for questions, please.
That's awesome. Thank you so much, Anna. I was just thinking we need little buttons that say, with the little hand, prescribing the antibiotic, hold the biologic. We need little buttons. So we've got a couple questions, and I've got some here too. So please, guys, chime in on the Q&A. Daniel's kicking us off. And actually, this gets into a little thing also on how these medications are actually given. So he says, what does holding the biologic look like for biologics which are given infrequently? Is it only relevant if they're due for a dose during the antibiotic course?
This is an excellent question. So some of our agents, like the targeted synthetic agents, are given daily or twice daily. Some of our agents are given once a week, every 2 weeks, every 4 weeks, every 8. They all vary, as you all know. And so this only really refers to if there's a dose that is meant to be given during the antibiotic course. If you have a patient who's on a Q4 weekly biologic and you're giving antibiotic for a week in the second week, there's nothing you need to do differently. If you're giving antibiotic in the fourth week and you're not sure if they may not have complete resolution of that infection, you may advise the patient just to hold off giving that dose at the end of the antibiotic course until you feel confident that the infection has resolved. But that's an excellent question. So sometimes we're lucky and people can time their infections and antibiotics in between doses, in which case no hold is required. But if a dose is due before the antibiotics are completed, that dose needs to be delayed. It does not need to be held till another, like if it's a Q4 weekly, you don't have to wait 8 weeks, but usually we'd say a few days to a week after the end of the antibiotics to ensure that the infection is adequately treated.
Follow on for that. So Murphy's Law, they just gave the injection like 4 days before. Should you be just planning on having a longer course of the antibiotics?
I think generally what we recommend is just a lower threshold to reassess. So I would give the usual course of antibiotics, but I might see them back to confirm that they're okay and that it doesn't need extending. We don't really want to promote antibiotic stewardship challenges with, doubling antibiotic courses or things like that, just empirically. But we really want there to be follow-up for those patients and making sure things are okay.
So anonymous attendee, don't be shy, guys. You can say who you are. What about holding biologics for surgery and healing concerns, especially surgeries that get intraoperative antibiotics? So there's a concern for possible bacterial infection.
That's an excellent question that I did not address. And I think if I were to give this again, I'll add in a slide about perioperative management, but I didn't know how far to go with some of these. So typically, most biologics we recommend holding 1 to 2 weeks prior and a week after surgery. And the 1 to 2 weeks prior depends on the half-life of that biologic. So if you liaise with your rheumatologist, we can give you some advice. And it also depends on the severity of that patient's disease. So a patient who's had deep remission for a number of years, you might feel more comfortable holding for a bit longer. A patient who's going into a surgery with active disease, that's never a good situation for infection management afterwards. Their immune system, when they have active disease, does not manage infection very well. So we try and hold it for less time to keep them as in control as we can during their surgery. And then we hold it for a week after to ensure they've had no immediate post-op infections and that wound healing is going okay. So that's our typical, and that's, I think, a guideline, not a rule. There's patients for whom I have restarted 24 hours post-op because they are so sick with their disease. And there's patients for whom I've held longer because the infection risk looked not as good, and I wanted to make sure that they're okay. But generally, we say a week or two before and 1 week after. And I want to highlight that we don't typically hold conventional synthetic DMARDs like methotrexate, hydroxychloroquine, leflunomide, or sulfasalazine. The reason for that is the infection risk associated with conventional synthetic DMARDs is very low, and most of them take 6 to 12 weeks to leave your system anyway, so holding them does very little. The only exception is methotrexate. We do hold if there's a risk of renal impairment because methotrexate is renally cleared. And so if you think the patient is at risk for an AKI, an acute kidney injury, in the perioperative period, we might hold it just to make sure their creatinine is okay post-op before reinitiating the medication because we don't want them to have escalating levels in their blood. I don't know if that helps.
Fantastic. So awesome. Okay, Joanna's asking us, can Actemra lower a patient's alpha-1 and 2 antitrypsin?
I don't know that answer. I'd have to look it up, but it isn't something that is standard in our counseling or monitoring of patients. So I don't want to give the wrong answer here. I'd have to look it up, but it is not a common side effect. It's not one I've ever encountered. We do screen patients with sulfasalazine, but I don't know about Actemra. I'd have to look that one up. I'm sorry.
Okay. And then Anibuchi is asking, what do we do if they develop a flare while holding the biologics during the bacterial infection?
Yes, this can certainly be an issue, especially if it's a serious bacterial infection like a septic arthritis and osteomyelitis, something that requires like a really prolonged course of antibiotics. This comes up more and more. And then we're stuck, right? There's no good answer. That's the quickie here. There is no good answer. And so we can try and temporize with NSAIDs as best we can. We can use steroid injections if it's away, if obviously not in an infected joint, but somewhere else. We might try that if we don't have a concern about seeding from another joint. Sometimes we use prednisone, but honestly, we do that, but that is not a very logical thing. We do that because it makes us feel better, but the infection risk of prednisone is probably higher than that of biologics, to be honest with you. And so we're replacing one infection risk with another, and we need to know that. So I think if you have to do it and you need to give a short course of prednisone, keep it short. So, in a rheumatoid, something like a lowish dose, like 20 milligrams for 5 to 7 days, if you can get away with it, extending and slowly tapering for as short an amount you can. And then be aware, I'm giving prednisone, I'm increasing their infection risk here. Do it with your eyes open is what I guess I would say. But it's a tough situation, and we just have to try and manage those risks as best we can and anticipate them. So watching that patient carefully when we give them prednisone if they're infected.
Awesome. Trina is asking, would it be helpful to provide a note for the person to take to the infusion clinic saying safe to proceed with the biologic once antibiotics are completed to avoid the nursing staff declining to infuse? So infusion scheduled for Saturday, nursing staff will ask if they had antibiotics. If yes, they might not be able to get in touch with the provider on the weekend.
Yeah, I would say maybe. If you feel really confident that this infection is going to be resolved by the end of this antibiotic course, then I think that that's a reasonable thing to do. The reason I hesitate is sometimes the nurses will call us and say, this patient finished their antibiotics on Thursday, they're presenting Saturday for their infusion, and now, the wound looks worse, they're coughing more, it hurts when they pee again that didn't. So that's the risk of giving them a note like that, is that you don't want to risk safety around. You have to feel quite confident that the infection is resolved if you do that.
Awesome. And Anne's asking whether there's any indication for antiviral therapy for people who maybe have COVID
Yeah.
Or flu, like.
Yeah, so the data that we have for immunosuppressed patients in the rheumatologic realm is that they do much better with Paxlovid if given within the first 5, occasionally we've done it within 6 days of symptom onset, so during that time of acute viral replication. And so in this population, they have shown, I think it's 88% decrease in ventilation or death in COVID patients who are on advanced therapy, immunosuppressive medications. So we do, and we try to counsel all our patients to request Paxlovid to test. It's increasingly difficult to get patients access to testing now. And typically, in the past, they've wanted positive testing for use of Paxlovid. I don't know if that's eased up recently, but yes, we do encourage the use of Paxlovid for COVID infection. In terms of flu, the guidelines are not as clear. In that case, I probably would have a low threshold, but we don't have as clear guidelines coming in terms of the evidence.
What's happening in that space with regards to coverage for Paxlovid in the outpatient space for rheumatology patients?
Um, I would say it is ever changing. I find it very difficult to keep up with because the rules are constantly changing, both around testing and around coverage. The last patients that I've had who've had Paxlovid were in January and they still got it. But I think, as you know, vaccines, COVID, Paxlovid, etc., these areas have become quite charged politically, and there is a lot of change that's happening. And so we have a PharmD in our clinic, and whenever this occurs, I go to her and she informs us of the most updated situation. But it is very tricky. Around vaccination, our patients are eligible for 6 monthly rather than annual COVID updates, those who are on biologic therapy.
And then we have anonymous again. How do I confirm resolution of infection? So fallen CRP, CBC diff, if pregnant but on biologics, do I stop until delivery? That sounds like a couple questions together.
Yeah, I was going to say, I think those are different issues if I'm understanding correctly. So I would say however you might clinically confirm. So if it's a wound infection, looking at the wound, definitely like to see their CBC improving. It doesn't have to be fully normalized, but improving, and their CRP improving. Again, doesn't have to be fully normalized. If it's pulmonary, improvement of symptoms. Basically, we want to see that there's ongoing improvement, not worsening. But it's really clinical, to be honest with you. We don't have rules around their CRP has to be less than 12 or anything like that. And then pregnant. Oh,
pregnant type people. What do we do about pregnant or planning
yeah.
pregnancy, or what do we do there, Anna?
Okay, so it varies by disease, and it varies by drug. And so my best advice is work with your rheumatologist and OB internist in this space. But generally, we continue anti-TNF agents through pregnancy. There is some question about whether they should be continued in third trimester because there's some active transport. There are some agents like certolizumab or Cimzia, which are designer drugs for pregnancy and childbearing age women because they have attached a pegylated moiety onto the structure, which prevents it from crossing the placenta. So when we have women of childbearing age, we preferentially try and choose drugs that would be safe to continue through pregnancy. But TNF alpha agents have been shown to be safe in pregnancy. Outside of TNF alpha agents, we don't have the data to support it. We just don't know if tocilizumab, Rituxan, etc. would be safe in pregnancy. And so in those cases, it's a very careful, informed consent discussion with a patient around their wishes, the risk of their disease activating during a pregnancy versus the risk of the drug, which is often not known in those circumstances. So we don't usually stop till delivery. The other thing I'll say about rheumatoid is about 2/3 of rheumatoid arthritis patients spontaneously remit during pregnancy. This is not a reliable source of disease control. We do not encourage pregnancy as a mechanism for disease control, but about 2/3 do remit in pregnancy. And likewise, about 90% will flare in the 3 to 6 months postpartum. And now they have a little baby who has those sleepers with all those stupid tiny snaps that never align and their hands can't function and they're miserable. So we really watch for postpartum flares, which is why we typically will continue these drugs to avoid that.
And Velcro's onesies.
Zippers.
So, hey guys, there's a subtle hint on the screen in the form of a large QR code while we continue to answer questions here. If you would be so kind as to give some feedback. Your feedback was so instrumental in the feedback from our Rheumatology 1. So, and I see you leaving. Hopefully you're getting your QR codes before you leave. Please, please, please fill them in. Okay, one more here. How helpful is ordering a CRP in patients when working them up for other conditions while on these medications? Can I order it and interpret it normally?
I love this question. Okay, so it's not as straightforward a question as you might think. but it's a really important one. So as I think all of you know, CRP is an extremely nonspecific blood test that shows some kind of derangement somewhere, anywhere in the patient as a result of an autoimmune condition, an infection, a malignancy, trauma, big surgery. Any of these things can cause elevated CRPs. And so if their autoimmune condition or rheumatoid arthritis or other type of disease is in good control and you find an elevated CRP that can't otherwise be explained, I think that is important to follow up. But there's a caveat. Some of these medications, namely IL-6 blockers, so tocilizumab or Actemra, ixekizumab or Taltz, just a minute, JAK inhibitors, those ones interfere with the CRP assay. And so actually in those cases, we tend to use CRP more as a marker of adherence. If a person who's on tocilizumab has an elevated CRP, my bet is they're not taking their tocilizumab. And so in those diseases, a person could have infection, malignancy, trauma, other reasons for elevated CRP and not mount a CRP. And those are the rare occurrences where we have permission to do an ESR. And typically you'll see if you order an ESR on any of the electronic platforms, it'll say, is this patient on a particular biologic? Because they know that patients who are on tocilizumab, you can't tell with a CRP. That's where we do an ESR. So there's small cases, but please do not rely on a CRP. Some of these medications do interfere with that assay.
Wow. Well, I think you have done a masterful job, Anna, on plowing through a whole bunch of awesome questions with 4 minutes till your clinic. Uh,
Yay.
Great talk. So just want to, on behalf of everybody, thank Anna for part one of Rheumatology 2.0. Just really appreciating all the colleagues with all the teaching coming in from rheumatology. Um, and lots of people chiming in with thank you. And yes, to those who weren't there at the beginning, you will get a recording in a week, as well as the Pearls document with the highlights that Anna's gonna edit over before we send out. So it's usually about a week or so after this presentation. And everyone's saying
And I
thank
thank you all for your interest. Yeah, and we're always at the other end of a phone call.
yeah, thank you, Anna. It's
Thank you.
really appreciate this and lots of great feedback. So please do your evals, guys. Just really love to have your inputs and thoughts about future sessions as well. Yeah. And thanks to the team. Thanks to Andrea and Natasha and Dr. Slamy, who's going to be moderating some of these later sessions, for being here today as well.
Thank you. Denise, would you like me to stay on at all or?
Hey, well, 2 minutes before you run away. Yeah, people are just going, but no, thanks, Anna. That was really great. Yeah.
Okay, I hope it wasn't too much information. I was like, what would a family doctor want to know about this stuff?
No, very good. And I think the questions were fantastic.
Yeah.
I think some of those ones, there was a couple that came up in the questions that we should maybe grab for the pearls. Yeah, no, super. This is such an important area, and truthfully, like it's just such a black box. Um, I had two questions that I didn't ask. So,
Sure.
so one of them was, should there be any differences on our screening? Like, should I be doing skin surveys on all my patients?
We do
Or
recommend skin surveys, yeah.
yeah, and then the
Even rheumatoid, like without biologic, rheumatoid increases non-melanomatous, then rheumatoid with methotrexate, a little bit further increase, and then with biologic, a little bit further increase.
yeah, and then the other one was, I've had a weird situation with some different consultants from different disciplines wanting to stack biologics.
Yes,
So
that is a really,
there was going to be a scenario with like 2 or 3 biologics on one patient, and then the note from the consultant was, "And the family doctor can manage." And my comment in my head was, "I cannot." Like I sent this back to them, going,
yeah.
"I feel very uncomfortable with the combo of these."
We just had rounds last week and had this discussion, like when are we going to have the data that's, helping us around safety? Which of these combinations are okay? As biologics expand into asthma, migraine, like you name it, people are on biologics for all sorts of reasons. And I think some of those agents seem to have lower infection risk, but I also have seen, my dermatology colleagues starting one agent that targets a similar pathway to my neurology colleague, to my, rheumatology colleague. And then you've got people on combo biologic therapy. And that is a emerging area, combo biologic therapy, even if they are in the same kind of immunologic domain. But we have very limited data around that. And so it's really, it needs a good informed consent discussion. And I have sent letters to my colleagues saying, you started this biologic on a patient who's had, the worst one is Rituxan, because rituximab, they get it every 6 months. So it doesn't always show on people's med list, or they don't think about, yeah, I also am technically on rituximab because it lasts for so long. And then someone will add in a second biologic and you're like, whoa, now they're kind of on two, hey? So it's a huge problem and a good question.
Certainly not something I feel comfortable managing. Denise will
Yeah.
like, no, no, Denise will not.
Push
Anyways,
it on us.
yes. Oh, actually, Jean-Pierre is asking a question. How do you customize malignancy risk for 50s when indication is a dermal condition? Um, oh,
So if the person already has non-melanomatous skin cancer, it's it's important to tell them that there is a risk of increase, but it is very small, and they need, closer surveillance. But I find it really important to weigh the risks and the benefits. And people often think about the risks of the drugs. These drugs have risks, but what they don't think about is the risk of uncontrolled disease. And I try to emphasize to them, these diseases, uncontrolled, shorten your life expectancy by 21 to 26 years. And so we can't only think about the risk of the drugs, we have to think about the risk of no drug as well. And in some patients, that discussion can go well. Some patients, as you know, are extremely frightened of drugs, or have, concerns that are harder to allay. And my advice is never to arm twist someone into a drug they don't want, because they're the ones who are going to get the side effects. So yeah, I don't have a perfect answer for that.
wow. Yeah, such a great area. And thanks for all your wisdom and knowledge about this and for teaching today. Really
Yeah.
appreciate you. And have a
Okay.
great clinic. We're getting you
Thank
on
you.
time into clinic to like cruise through the afternoons. That's awesome. Thanks so much.
Perfect. Thanks again, all of you. Thanks for the support, Andrea and Tessa, and thank you, Denise.
Good to see you, Anna.
Bye.